Hi, this is Brian Kim. I'm going to share with you case number 65 in the Best Way to Do Cataract Surgery series. This is a 2.4 millimeter incision and moderately dense lens, and you're going to see systematic lens disassembly with double chop, cross chop, and mechanical fracturing. This is my standard technique for pretty much all of the types of cataract surgeries that I do. So I'm using a corneal marker to help me center and size my rhexis, and I'm using a cotton tip to steady the eye. And then I'm using a diamond blade to make a paracentesis incision on the right side and left side. I'm making my incision flat to the iris plane, parallel to the iris plane, which creates a nice corneal shelf, which allows me to make a nice self-sealing corneal incision. I'm injecting intracameral lidocaine and then some dispersive viscoelastic to fill the anterior chamber and to flatten the anterior capsule. This is a bi-beveled technique. With the metal blade, I stab the cornea just near to the limbus, tunnel through the cornea, and then enter using the cannula to help support the eye. I inject some more viscoelastic after that maneuver before I do my rhexis. I feel like injecting a little bit more viscoelastic right before I do the rhexis gives me a little bit more control when I do my rhexis afterwards. So that's kind of the most recent change that I've done, is injecting a little bit more viscoelastic. I'm holding the cannula in the eye anyway, so I go ahead and inject that viscoelastic right before I transition to my rhexis. And I've noticed that I have less chance for radializing of the rhexis when I do this maneuver. So I finished the rhexis, I burped the viscoelastic out. This is the capsular fornix hydrodissection technique. I place the cannula out to the contralateral equator underneath the rhexis, get a nice fluid wave, decompress on the left side, turn the cannula tip down, point it on the right side, and it starts to spin quite nicely. So we're going to start the phaco now. I'm irrigating the surface of the eye to remove any debris. Making sure my tip is correctly exposed. I lift the incision with a chopper, go in with irrigation off to minimize Descemet's trauma. Remove the surface epinuclear material, place a chopper underneath the epinuclear ridge, turn the phaco tip vertically, subincisionally, crushing the lens and dividing it completely in half. That's the double chop maneuver. Place the chopper around the right heminucleus, pulling it centrally towards the phaco tip. That is the cross chop maneuver, dividing the right heminucleus. Use a little bit of vacuum to hold that first quadrant, support it, and then place the chopper around it and crush it. You see I'm using successive crushing forces, sandwiching and crushing and dividing the lens between the chopper and phaco tip. And then once the pieces are small, I emulsify the lens pieces. You can see how efficiently I'm able to do that maneuver. Place the chopper underneath the second quadrant, pulling it central toward the phaco tip, crushing and dividing the lens now. Do it again, the same maneuver, crushing the lens between the chopper and the phaco tip. Use a little vacuum to orient the lens piece. Holding it at the tip, crushing it, and then emulsifying the lens piece. Same thing here, putting it to the tip with a little bit of vacuum, and then crushing the lens piece, and then emulsifying the lens piece. I'm going to turn the second heminucleus in front of me, place a chopper underneath the rhexis edge out to the equator, pull it centrally towards the phaco tip. The phaco tip is deep. Dividing that heminucleus in half, place the chopper around that third quadrant, pulling it centrally towards the phaco tip, dividing that lens piece. Sandwiching the lens piece, crushing it between the chopper and the phaco tip, and then emulsifying the lens pieces. So again, this is a fairly dense lens. It's not really exceptionally dense, but it's kind of an average density. You can see how controlled the maneuvers are. Again, crushing the lens piece between the chopper and the phaco tip, and then emulsifying the lens pieces. Again, during the crushing maneuvers, there is no ultrasonic energy or vacuum used. This is a very systematic, slow and controlled way to break down the lens piece into smaller pieces and then emulsify the lens pieces. So this is the fourth quadrant here. I'm rotating it, place a chopper around the lens piece, placing the phaco tip deep, bisecting the lens piece, using a vacuum to position the lens on the tip, and then crushing the lens piece before emulsifying. So I use a little vacuum to position the lens piece, but then I crush it first before I emulsify the lens piece. Most people would just go pedal to the metal and just emulsify the lens piece, but I like to break it down even more before I actually emulsify the lens. Again, this reduces CDE, which in my opinion also protects the corneal endothelium and achieves clear corneas afterward. So I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. Starting to remove the cortical material, but it's a pretty clean bag. So I quickly switch to the polish mode, especially since the pupils come down a little bit and I can't really see the rexus edge. I like to switch to polish mode early when I really can't really see the capsule. Now I'm starting to polish the posterior capsule surface, especially in the subincisional area. There's some fine cortical material there, and I'm teasing it off the posterior capsule. I'm polishing under the rexus edge to remove lens epithelial cells. We'll take the BSS cannula, place it underneath the capsule in the subincisional space, pulse it, and you can see this cortical material start to be liberated. I grasp it with the INA handpiece and start teasing it out. I'm flushing a little bit more. You can see there's more cortical material coming out, and I was able to remove it with the INA handpiece. Place some cohesive viscoelastic to fill the capsular bag, and now I'm using the sweep to polish first on the left side underneath the rexus edge to remove any lens epithelial cells, and then I'm polishing on the right side. I'm injecting the single piece acrylic intraocular lens into the capsular bag. The leading edge will go into the bag and the trailing edge will be out of the bag. I quickly place the INA handpiece in, inflate the eye, disengage the haptic off the optic, both leading and trailing, go under the lens, tilting it and then rotating at 90 degrees, removing all the viscoelastic from within the bag and underneath the lens, seating the lens back into the bag, switch to polish mode, starting to polish underneath the rexus edge, which also helps me rotate the haptics in the horizontal meridian. And then I switch to the visco mode to remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, you can see lately I've been using the 2.4 millimeter incision, which will be my new incision. And you can see that with the pink sleeve. The pink sleeve indicates a little bit of a smaller incision size. You saw that I performed double chop, cross chop mechanical fracturing techniques to very systematically and carefully disassemble the lens by using sparing amounts of ultrasonic energy and vacuum, which does allow me to have clearer corneas after surgery. And clearer corneas, of course, means happier patients because they see better. You saw that the 2.4 millimeter incision hasn't really affected my technique with my rexus. It does require a little bit more effort because you can't open the teeth completely open. Again, I like to inject some more viscoelastic after I make my incision. It does help to stabilize and flatten out the anterior capsule to help with capsular rexus. So I hope this was helpful to you, and I thank you for your attention.